Welcome to this presentation in updates in diabetes prevention. It is brought to you by PharmPH LLC. Now, the audience for this presentation is specifically health educators. However, any healthcare professional that's working in diabetes prevention is more than welcome to listen to this presentation because I feel like there's a lot of important information that's covered. However, it is accredited only for credits for CHES and MCHES folks. Also, individuals who are certified diabetes educator can utilize this course to gain credits for their certification as well. In order to receive credits for this presentation, you first need to view the presentation, and upon viewing, you need to complete a post-test. You need to achieve at least a 70% on the test in order to get credits. Additionally, you need to complete an evaluation form that's attached to this presentation. So I kind of structured today's presentation into 3 different lessons. The first lesson will talk about the Medicare Diabetes Prevention Program. Now, I want to preface this by saying that we do have a course on prediabetes. We've had this course for about 2 years now, and I think it's a good segue to this particular presentation. It's not mandatory that you take it in order to understand today's lecture, but I feel like the contents presented in that course will kind of help you understand the Medicare Diabetes Prevention Program a little bit better. So if you haven't, please take some time and purchase that course. The second lesson, we'll talk about how to get involved in diabetes prevention. We'll hope to explore how the health educator specifically can get involved and the collaborative opportunities that exist for the health educator. And in the last lesson, we'll talk about a guide to diabetes lifestyle intervention. I know some of you might be working in chronic disease prevention. You might have patients as a community health worker that you serve. Hopefully, in the third lesson, you will learn about lifestyle interventions for diabetes prevention and how to work with affected individuals. At the end of this lesson, you should be able to explain the foundations of the Medicare Diabetes Prevention Program. You should be able to identify forms of CDC recognition for such programs, and then be able to describe what it takes to be a Medicare Diabetes Prevention Program supplier versus a Medicare Diabetes Prevention coach. Now, going forward, you will hear or see the abbreviation MDPP, and that simply means the Medicare Diabetes Prevention Program. A quick recap as to how we got to this point. In one of my earlier courses, Prediabetes, a window of opportunity for intervention, we covered the basics of what prediabetes is all about, and I mentioned this earlier on as I was introducing today's topic. We also talked about the National Diabetes Prevention Program, how it came to existence, and the rest of them. So if you really want more details, feel free to take a look at that course. This activity is more of providing knowledge on what's going on in the field of diabetes prevention. So let's get started. For those who are unaware, prediabetes is a condition where your blood sugar is high, but not high enough for you to be classified as having full-blown diabetes. It comes before type 2 diabetes, but can be prevented or delayed. The Diabetes Prevention Program, otherwise known as the DPP, is a program that came out of a national study which showed that lifestyle interventions or metformin can prevent or delay the onset of type 2 diabetes. Ever since that landmark study showed positive results, it's been replicated in community settings. So the beauty of the DPP is that it is facilitated by health coaches who aren't necessarily healthcare professionals, but have gone through a standardized diabetes prevention program lifestyle coach training. The DPP is being offered in various community settings, and there has been efforts made by the CDC and other agencies to get employers, insurance companies, and the like to offer this program as a covered benefit. Speaking about coverage for the diabetes prevention program, the biggest win, however, is the coverage by Medicare. Starting January 1, 2018, Medicare will offer the diabetes prevention program as a covered benefit to its beneficiaries. You will often hear the term Medicare Diabetes Prevention Expanded Model. This simply refers to Medicare's expansion of the Social Security Act to include the diabetes prevention program as a covered benefit to eligible beneficiaries. So how did we get here? 25% of Americans 65 or older have type 2 diabetes, and diabetes care for the 65 plus population costs about $100 billion annually, and that figure keeps growing. One of the good things about the Affordable Care Act was that it allowed for the creation of the Innovation Center at the Center for Medicare and Medicaid Services, otherwise known as CMS. And since that creation, CMS has been testing new delivery models. One of the models to be tested was the Diabetes Prevention Program. A DPP model test was carried out between February 2nd of 2013 and January 2015. So that's quite a good number of months that the test was carried out. And this test was done amongst Medicare beneficiaries who were receiving the diabetes prevention program through the YMCA across different states and different sites. The results of the model test were strong enough to show both cost savings and improvement in the quality of care among the Medicare beneficiaries who participated. The result of this was a certification by CMS to expand the diabetes prevention program coverage to Medicare beneficiaries starting 2018. So there will be a zero copay for eligible beneficiaries who are participating in the diabetes prevention program. In this slide, I want to highlight the basics of the Medicare diabetes prevention program. Services available through this model are Medicare diabetes prevention program services furnished in the community and healthcare settings by coaches such as trained community health workers or health professionals. It is important to note that all programs seeking to offer diabetes prevention program to Medicare beneficiaries must utilize a CDC-approved curriculum, which I'll touch upon later on in the presentation. In 2017, CMS finalized the structure of the Medicare Diabetes Prevention Program services. The core benefit period consists at least of 16 weekly sessions over months 1 through 6 and at least 6 monthly core maintenance sessions over months 7 through 12. Payment for this 1-year core benefit is regardless of weight loss. Now, Medicare will cover ongoing maintenance sessions after the 12-month core set of services if beneficiaries achieved and maintained the minimum required weight loss of 5%. CMS has finalized the coverage of these maintenance sessions for another year post the core 1-year benefit period, hence making the total Medicare Diabetes Prevention Program service period a period of 2 years. Now, continued payment in the following year depends on beneficiaries meeting attendance requirements and weight loss goals that are set by Medicare. For those of us that are visual learners, this slide simplifies what I just talked about in the previous slide. This is just another way to visualize and summarize what we just talked about. In months 0 through 6, that's when the core sessions happen. Months 7 through 12, that's when the core maintenance sessions take place. And then your ongoing maintenance sessions happen between months 13 through months 24. Again, remember, in that first year, that's months 0 through 12, reimbursements do occur from Medicare regardless of whether the participant meets their weight loss or attendance goal. Now, when you get into the ongoing maintenance sessions, that's months 13 through the 24th month, beneficiaries have to meet attendance and weight loss goals for reimbursements to continue. So more about the Medicare Diabetes Prevention Program. Beneficiaries have to meet certain eligibility criteria, which we will talk about in the next slide or two. Additionally, if the beneficiary does develop diabetes, they will be allowed to continue receiving services during the service period. It is important to note that the MDPP is a once per lifetime coverage benefit. The beneficiary can only receive these services under Medicare once per their lifetime. I'm guessing if they have a supplement insurance that covers it, regardless of whether Medicare has paid for it before, that would be fine. But underneath Medicare, coverage is just once. Now, a beneficiary might switch between Medicare Diabetes Prevention Program suppliers, and that is fine. Medicare will still pay for them to continue to receive services. Makeup sessions are allowed for people who miss in-person sessions. These makeup sessions can be in-person or virtual. However, there is a limit to the number of virtual makeup sessions. I recommend keeping up to date with Medicare requirements for each physical year when it comes to reimbursement requirements for the Medicare Diabetes Prevention Program. I took this slide from a presentation by the Michigan Diabetes Prevention Organization. I wanted to talk about this also because the clinical indicators noted on this slide will help you in forming the basis of your referral. So on this slide, we're talking about the eligibility requirement for the Medicare Diabetes Prevention Program. Obviously, the participant has to be enrolled in Medicare Part B. There are BMI requirements. There's also a significant criterion when it comes to the blood sugar levels, and that is the blood sugar levels have to be obtained within the 12 months prior to attending the first core session. And remember earlier in the presentation when we talked about diagnosis of prediabetes and the glucose levels that correspond to the A1C test or the fasting plasma glucose test or the 2-hour post-glucose challenge. So those are reflected here as eligibility criteria as well. Other requirements, the person should not have had a previous diagnosis of type 1 or type 2, with the exception of gestational diabetes. That person should not have end-stage renal disease and should not have been a previous recipient of Medicare Diabetes Prevention Program services. What constitutes a referral policy for someone to the Medicare Diabetes Prevention Program or to Diabetes Prevention Program in general? Well, an individual who's completed the screening test, which we talked about earlier, can look at the results and see that he or she is at risk for prediabetes and may go ahead and self-refer him or herself to a diabetes prevention program. Now, obviously, for Medicare to pay for it, that individual has to meet those eligibility criteria that we talked about earlier. Their referrals can come from community resources. Healthcare professionals or practitioners can do referrals, and those referrals don't necessarily always have to come from a physician. Non-physicians, such as us pharmacists, can refer our patients to diabetes prevention programs as well. I know this slide looks a little bit busy, but it just kind of summarizes the payment structure for the Medicare Diabetes Prevention Program. CMS has finalized the structure for reimbursement for 2018. Remember, the way DPP works is such that there are core sessions and core maintenance sessions in the first year, and then for another 12 months, there are ongoing maintenance sessions. The payment structure for the Medicare DPP is an incentive-based payment model. In the first 6 core sessions, payments are made regardless of weight loss, but afterwards, the amount of reimbursement depends on whether the participant achieves at least a 5% weight loss. And at any time, if the participant achieves 9% weight loss, additional money will be paid. So if you walk through the chart, the max reimbursement per beneficiary for the 2-year period is $670. And with that slide, we can do a quick math. Assuming the person attends all 9 sessions in the first 6 months, you can expect to be paid $165. And then for the core maintenance sessions, assuming they achieve 5% weight loss, max you can get is $120. And then for achieving the 5% weight loss, you get an incentive of $160. And that brings our total so far to $445. Now you move on to the maintenance sessions. Assuming they make all sessions with a 5% weight loss, that's a max of $200. When you add $200 to $445, excuse me, you get a total of $645. And then for 9% weight loss, should that happen, you get an additional $25, bringing us to that max total of $670. Who can furnish MDPP? Organizations that offer the Medicare Diabetes Prevention Program to beneficiaries are referred to as MDPP suppliers. There are eligibility criteria for enrollment into Medicare as a supplier of the MDPP, and one of such criteria is obtaining CDC recognition for your diabetes prevention program. Now, you could have been a Medicare provider of other services. That doesn't mean you are qualified to be a Medicare Diabetes Prevention Program supplier. One criteria for becoming a supplier of the MDPP is to obtain recognition from CDC, and we'll talk about this in the next slide. CDC offers 2 types of recognition for diabetes prevention programs. One of them is the preliminary or pending recognition, and the other is full recognition. All CDC recognized programs have agreed to use a CDC-approved curriculum that meets the requirements noted in the Diabetes Prevention Recognition Program, or the DPRP standards. If an organization wants to offer the DPP and agrees to follow the curriculum, duration, and intensity requirements, they will receive preliminary or pending recognition. The recognition status is then evaluated after 24 months. If that organization meets all requirements outlined in the DPRP standards, they will be granted full recognition. Organizations continue to submit data to CDC and receive evaluations. I mention these types of CDC recognition because CMS has established that full recognition is one of the eligibility criteria for a program to enroll as an MDPP supplier. Now, because attaining full recognition status can be difficult and takes time, CMS has proposed to allow entities that have not achieved CDC full recognition to still enroll as MDPP suppliers if they meet interim preliminary recognition. You meet preliminary status of recognition if you have 12-month worth of data submission. There's more to the MDPP enrollment, but these are some of the basics that I thought I would highlight in today's webinar. Beginning January of 2018, organizations can start enrolling to become Medicare suppliers. Reimbursements, however, are proposed to start in April 2018. It is important to note that organizations and not individuals can register to become a supplier of the MDPP. The enrollment fee is $560 for the 2017 fiscal year, so it's a little bit of investment there. Suppliers have to meet and maintain several compliance standards. For example, a supplier cannot be terminated from Medicaid. They also have to submit quarterly evaluations. There are IT and infrastructure requirements as well that have to be met in order to comply with Medicare. You have to be able to submit and transmit claims to Medicare, attest to participant submission of weight loss, etc. Lastly, MPI numbers. Suppliers need to obtain an MPI number at the organizational level. Lifestyle coaches also need to obtain their own MPI number. National diabetes prevention organizations will need to submit a roster of coach MPIs, names, and social security numbers to CMS upon applying for enrollment as a Medicare diabetes prevention program supplier. Any individual can be a lifestyle coach for the diabetes prevention program, including health educators. The key thing to note is that CDC recognized lifestyle change programs must have lifestyle coaches who are trained to use the CDC approved curriculum and who have the knowledge and skills to effectively deliver the program. If your organization needs training for your lifestyle coaches, the organizations listed below in this slide can help. These organizations have signed a memorandum of understanding with the CDC to provide training. Some of them can also provide training for master trainers who can, in turn, train lifestyle coaches for their own and partner organizations. This brings us to the end of Lesson 1. In this section, we talked about the evolution of the Medicare Diabetes Prevention Program, how it came into being through an innovation project and its structure. Then we talked about the big win which was achieved, and that is the DPP being offered as a cover benefit to Medicare beneficiaries. And finally, we talked a bit about the Diabetes Prevention Program suppliers and coaches and what's involved. Now that we have this foundation, we will move on to talking about the role of the health educator in diabetes prevention. In my opinion, this is an exciting time in the field of diabetes for public health and clinical medicine to mesh together for one common goal. In this section of the activity, we will talk about the roles or ways health education specialists can be involved in diabetes prevention. We will cover some good information in this section of the presentation, and hopefully it will give you some ideas as to how you can go about your work as a health educator when it comes to diabetes prevention. Some of the objectives of this lesson: at the end of this lesson, you should be able to list at least 3 ways health educators can be part of diabetes prevention efforts. You should be able to identify opportunities for collaboration, and you should be able to articulate 2 key strategies that focus on community efforts for diabetes prevention. As we delve into how health educators can be part of diabetes prevention, I wanted to start off with this infographic, which kind of gives an idea of the magnitude of the problem. 86 million Americans have prediabetes, which is about 1 in every 3 Americans. 9 out of 10 of them don't know they have it. More than 30 million Americans have full-blown diabetes. Now, the American Diabetes Association released new research in March of 2018, estimating that the total cost of diagnosed diabetes have risen to $327 billion in 2017. This is up from the $245 billion that it was in 2012 when the cost was last estimated. There are direct and indirect costs to diabetes treatment and management. People with diabetes have healthcare costs that are 2.3 times more than those without. So the moral of the story is, it is possible to prevent type 2 diabetes and/or delay its progression, and there is a huge window of opportunity for intervention. One of the most important things a health educator or any health professional, as a matter of fact, can do to be part of the national effort to prevent diabetes is to raise awareness about diabetes prevention itself. Now, I know health educators work in various settings, so how you go about promoting awareness might vary based on your work setting. But in general, as a health educator, you can do this during health screenings or tabling events where you hand out pamphlets on health information. If you happen to work in the corporate wellness department, you can most certainly look into ways on how to bring this information to the employees. If you are a health educator with an insurance company, by all means promote awareness about diabetes prevention. Get your insurer to follow the steps of Medicare and provide coverage for non-Medicare folks. That is, if your insurance is already not providing diabetes prevention coverage. In general, talk about benefits of preventing diabetes and what happens when it gets ignored. Also, it is important to get to know the prevention programs that are currently existing in your community so that you're able to refer participants and those people that you work with to these programs. What you see on this slide is from CDC's website. I encourage each and every one of you to check out the website that's listed at the bottom of the slide. When you visit the link, you will see a tab that allows you to find a diabetes prevention program in your location. So it's definitely a great tool to have and utilize as you in your work as a health educator. Another way for health educators to get involved in diabetes prevention is to first become a lifestyle diabetes prevention coach themselves. Various organizations throughout the nation offer trainings for one to become a coach, and some provide NCHEC approved CE credits for training. And we talked about some of these organizations that provide trainings earlier on in the presentation. So numerous studies have demonstrated the impact of community health workers, health educators in improving chronic conditions. So there is a great potential for reaching a vast number of people with prediabetes. As you think about your scope of practice as a health educator, consider becoming a trained diabetes prevention lifestyle coach. It can definitely add more meaning to the work that you do. And if you work in a community-based organization, you can certainly encourage your organization to become a provider of the diabetes prevention program. In order to receive reimbursement, you definitely have to become a lifestyle coach that's affiliated with a diabetes prevention program. And as we mentioned earlier, Medicare will begin reimbursing for this starting 2018. So there's definitely an incentive for healthcare professionals to be involved in diabetes prevention. Health educators can definitely get involved by actually delivering the program itself. And this starts with first becoming a trained coach, then obtaining CDC recognition. If you are first starting out, you will have to seek for preliminary recognition from CDC. Then after the first year of running the program and submitting data to the CDC, then you can seek for full recognition. When delivering the program, you want to build sustainability into your program, and we'll talk about some ways to achieve that later on. You also want to ensure that you meet the standards set forth by CMS, that is the Center for Medicare and Medicaid Services, as this allows your organization to bill for reimbursement for delivering the program. The point I want to make is that there is a viable opportunity here for a health educator to expand the scope of his or her practice. Keep in mind that Medicare diabetes prevention program suppliers are organizations and not individuals. So there are various ways one can go about delivering the program, either by doing so for the organization or company that you're working for, or starting your own nonprofit that focuses on diabetes prevention. Just some food for thought, and you can definitely explore the laws in your state and what it allows you to do. CDC has somewhat simplified things for people who want to implement the diabetes prevention program. I show this page on the left just to illustrate that there is a wealth of information available through the CDC for those who want to get started in implementing the diabetes prevention program. There are factors to consider when delivering the DPP. The CDC estimates that it costs about $500 per person to deliver the program, depending on promotion, recruitment, logistics, etc. However, these costs can be lower if the program is delivered efficiently and effectively. That's where partnerships can come into play to make a difference. I want to take a step back for a moment and talk about costs versus benefits. Sometimes you can't really talk about diabetes prevention from an employer's perspective or from anyone seeking to offer it as a covered benefit without looking at the cost. And I'm sure also some of you are thinking about in your heads, depending on the setting where you work in, you're probably asking, is it going to be cost beneficial or cost effective to even offer this program? According to the CDC, of the average $13,700 annual medical cost of a person with diabetes, about $7,900 is directly attributable to the disease. On the other hand, the average cost of offering a lifestyle change program to a person at risk of type 2 diabetes is about $500. You want to look at your return on investment from the cost savings perspective to the employer, state, or insurer offering the program. This has already been proven, so we know a good deal of return of investment exists with offering diabetes prevention programs. The last but certainly not the least, you want to take into the account the quality of life years gained for the person who, without the diabetes prevention program, would have otherwise developed diabetes. This slide and the next just goes over a quick exercise on return on investment versus costs versus benefits of offering the diabetes prevention program. So in this exercise, we are using a return on investment tool provided by the American Medical Association to help jumpstart the conversation on offering the diabetes prevention program as a benefit to employees. In this exercise, the employer has 200 and 2,600 employees. It is going to cost the employer about $450 per participant to offer the program. Now, assuming anywhere from 10 to 50% of the pre-diabetic employees enroll into the program and about 40 to 70% of them actually complete the program. Let's see what the return of investment will be for this employer. In this exercise, we see that offering the diabetes prevention program to these eligible employees can save the employer up to $91,000 over 3 years. There are other tools out there that can help with cost estimation. This one is CDC's Prevention Impact Toolkit that can help with projecting the health and economic cost of a national diabetes prevention program or similar program on your population at risk for diabetes. Being able to implement a diabetes prevention program is one issue. Sustaining and scaling it up to meet other needs is a separate issue as well. And we talked about some of the concerns with the diabetes prevention program earlier on in the presentation. Definitely, it is great news that Medicare will be reimbursing for the program starting April of 2018. It's a step in the right direction. Hopefully, this will set stage for more insurers to begin to offer it as a covered benefit. But the question is, for those non-Medicare patients who can benefit from diabetes prevention programs, what happens to them? Because they currently don't have Medicare, which we know is the one insurance that's reimbursing for providing those services. But what about your non-Medicare patients who don't have it as a covered benefit? How can such programs be offered to them? The key to scaling up diabetes prevention programs lies in collaboration. We can't do it alone, and certainly one entity can't do it by itself. Diabetes prevention is a national and collaborative effort. In order to sustain nationwide efforts at preventing diabetes, it will require pulling resources together and joint partnerships to make it happen. Physicians, insurance companies, employers, state health departments, and the rest have to come together for this cause. There's been data showing interest from insurance companies when it comes to diabetes prevention programs, but we've seen slow adoption by many of them. Employers must also be willing to offer the program as a covered benefit to its employees. Now, from my experience in my outreach experiences, I can tell you that it is one area employers are struggling with, and that is chronic disease management and how to bring resources to the employees because they realize the missed productivity, reduced productivity, absenteeism, and the rest of it, those indirect medical costs that the employer has to bear due to disease states such as diabetes or unmanaged blood pressure. So in terms of community partnerships and linkages, I think this is where there is room for health educators to play a role. So I'll definitely spend a little bit of time in the next few slides talking about what exactly those community partnerships are and what those linkages look like. Community clinical linkages are connections between the community, clinics, and other settings where primary care is provided to improve population health. These linkages connect clinical providers, community organizations, and public health agencies. Amongst others, the goals of community clinical linkages include coordinating healthcare delivery, public health, and community-based activities to promote healthy behaviors. It also includes forming partnerships and relationships among clinical, community, and public health organizations so as to fill gaps where services are needed. These types of community clinical linkages can include developing ways to refer patients to resources. It can also include coordinating services between different locations, etc. Community clinical linkages are important because collaborations between clinical, community, and public health organizations offer a win-win scenario for participating organizations, clinical teams, and patients. They can help patients get more help in changing unhealthy behaviors. Clinicians get help in offering services to patients that they cannot provide themselves. And also, community programs get help in connecting with clients for whom their services were designed. CDC is a big advocate and proponent of community clinical linkages, and they promote this as well for diabetes prevention. CDC's Division of Diabetes Translation, DDT, funds state and local health departments to support programs and activities to prevent or delay the onset of type 2 diabetes. CDC's funding activities are part of two multi-program cooperative agreements, 1305 Cooperative Agreement and 1422 Agreement. Both cooperative agreements focus on 4 domains of chronic disease prevention, namely epidemiology and surveillance, environmental approaches, healthcare system interventions, and community programs that are linked to clinical services. The diabetes efforts under 1305 agreement fall under domains 3 and 4, while that of 1422 falls under domains 2 and 4. The common factor here is that CDC is committed to community programs that are linked to clinical services. I mentioned earlier that CDC is a big proponent of community clinical linkages. Each strategies under these funding agreements reinforce that. They have goals to increase the use of diabetes programs in the community setting. They also want to increase participation in the diabetes prevention program that we have been talking about thus far. I want to highlight the last bullet point, especially for those looking for collaborators or ways forward when it comes to diabetes prevention. State health departments are potential collaborators in this overarching public health goal. This last bullet point also highlights the fact that one of CDC's key strategies is to increase the use of healthcare extenders, specifically community health workers and health educators in the community in support of self-management of diabetes. By funding state health departments, they are giving health educators a platform to be involved. I would encourage you to reach out to your local state health department to see what initiatives or opportunities they have. This slide just talks about some of CDC's key strategies under the agreements 1305 and 1422. And some of these strategies include facilitating bidirectional referrals between community resources and health systems, and lifestyle programs that we've been talking about throughout this presentation. Another strategy includes the facilitation of identifying people who have undiagnosed blood pressure and people with prediabetes, as well as engagement of community health workers so that they are able to promote linkages between health systems and community resources for those people who have high blood pressure and adults with prediabetes. So this brings us to the end of our second lesson in this presentation, and we did cover quite a bit of information. We talked about the role and opportunities for the health educator. We talked about community clinical linkages and what they are, and we also talked about CDC strategies under the cooperative agreements. And so we'll move forward with the third lesson, which will conclude the presentation today. On to our last section for today. In this section, I will provide you with a guide on lifestyle interventions for the patient with prediabetes. You can also use it for those with diabetes as well. I feel that as health workers and coaches, it is important to know how to educate these individuals and point them in the right direction. So we are going to review some key concepts for making lifestyle interventions. Hopefully, these are pointers that you will find useful in your patient education and community outreach work. At the end of this third lesson, it is my goal that you should be able to list 4 components of lifestyle interventions, identify key strategies for physical activity and weight management, and be able to describe 4 elements of patient activation. The purpose of this guide is to help health educators and lifestyle coaches to understand and operationalize lifestyle interventions to prevent or manage patients with diabetes. All recommendations are evidence-based and adopted from the Centers for Disease Control and Prevention, that is the CDC's Prevent T2 curriculum, and the American Diabetes Standard of Care guidelines. In addition, sprinkled throughout this guide are clinical pearls of wisdom to help you navigate your patients in real-life problems, find detours around obstacles, and plan for success. The first element in fostering lifestyle intervention is creating an activated patient. The best care plan is meaningless when patients are not activated and engaged in their care plan. The American Diabetes Association recommends patient engagement as a foundational pillar to managing prediabetes or diabetes. Without an activated patient, lifestyle interventions become a hopelessly formidable challenge. So how can a health educator or lifestyle coach create an activated patient? In the conventional paradigm of an expert-to-patient relationship, the expert provides a care plan and patients adhere to it. This model has poor outcomes and is not a patient-centered approach. In contrast, the expert needs to leverage a strong rapport and supportive relationship with their patients in order to create a care plan. From a clinical perspective, a useful strategy to create an activated patient is to see the management of diabetes as a game. Like any games, there are 4 elements: rules, outcomes, progress, and opt-in. The first one is rules. Let the patient know the rules of the game, such as caloric restriction or amount of exercise. These rules need to be clear so the patient knows when they are stepping outside the boundaries. Outcomes. All games have a price, and in the management of diabetes, the price is to prevent the long-term complications. Patients need to be aware of these complications and educated about the healthcare consequences. The third is progress. In any game, players know whether they are winning or losing. So this is no different in diabetes, and patients should understand their glycemic control, such as the hemoglobin A1C, and be made aware if they are doing an excellent job or not. The last one is opt-in. Understand that you cannot force any patient to do what you want, and patients need to be internally motivated to play the game. Learn what your patient goals are. For example, some may have the goal of seeing the birth of their grandchildren or staying healthy so they can take care of their spouse. Whatever the reason may be, identify the reasons for patients to opt in and play this game. The second factor to consider when counseling for lifestyle changes is weight management. The key point is that patients should aim to lose between 5% and 7% of their starting body weight. This will seem like a tall order for some people, but it is important for you as a lifestyle coach to help your patients realize small steps, normalize setbacks, and gain confidence in the progress that they are making. In this section, we'll talk about tips that will help your patients in managing their diet. The MyPlate method is a simple strategy adopted from the American Diabetes Association. It divides the standard plate into portions and recommends a healthy portion size for each food group. I'll show you a visual of this plate in the next slide. The food groups we are referring to are carbohydrates, proteins, and fats. Carbohydrates are divided into 3 subgroups: starches, sugars, and fiber. In the MyPlate method, the ADA recommends at least half of your plate to be non-starchy vegetables, such as broccoli or lettuce, and a quarter of your plate to be grains and starchy carbohydrates like potato, pasta, or rice. When preparing vegetables, instead of using heavy dressing, try to use herbs, spices, lemon juice, and low-fat dressing. Out of the 3 carbohydrate subgroups, you should advise your patients to limit the amount of sugars in their diet. Sugars are usually calorie-dense and rapidly spike your blood sugars in a short time frame. The third subgroup is fiber, and fiber is likely under-consumed in most diets, but it can dramatically help improve your patient's weight. Fiber is not absorbed into the body and passes through the GI tract, which makes it calorie-free. It creates a feeling of fullness when you eat and slows down the digestion of food in the GI tract, thereby leveling out the spikes in blood sugars. In addition, fiber is also very useful as a non-medicinal agent to treat constipation. You should advise your patients to target between 25 to 30 grams of fiber intake per day. Now, not everybody tolerates fiber very well, and too much of it can cause bloating, flatulence, and stomach upset. So advise your patients to slowly increase their fiber intake so their body adapts to it. The second food group is proteins. According to the ADA, proteins, which includes eggs, fish, lean meat, and seafood, should comprise of a quarter of your plate. When consuming proteins, it is important to avoid the fatty parts, such as the chicken skin and the use of lean ground beef. To cook protein, use a non-stick pan and cooking spray rather than butter in order to spare unnecessary calories from fat. Now, speaking of fat, fat can be a dangerous food group if it is not tracked and understood. Not all fat is unhealthy. On the contrary, fat is very important to our metabolism as it keeps basic cellular structures like cell membrane intact and provides storage for extra calories to be used when fasting. Healthy fats include your monounsaturated fats, which includes things like avocado, canola oil, and olive oil, and polyunsaturated fat, which includes corn oil and sunflower oil, as well as omega-3 fatty acid, which is usually contained in salmon, sardines, and albacore tuna. The unhealthy fats are the ones that we need to avoid, and these include the saturated fat contained in things like chicken skin, regular ground beef, and lard. Trans fat is also unhealthy, and we find that in stick margarine and high in cholesterol. These are the kinds of fat that cause blockages in your blood vessels. So the summary of it all, you should make it count. Counting your daily caloric intake can be a frustrating process and challenging to sustain. Fortunately, there are many apps that can be downloaded and seamlessly integrated when planning a meal. There is a strong scientific evidence to demonstrate weight management can delay the progression of diabetes. The American Diabetes Association recommends a general caloric deficit of about 500 to 750 kilocalories per day for all patients. The total daily caloric intake for women should be about 1,200 to 15 kilocalories per day, And for men, it should be about 1500 to 1800 kilocalories per day. Make each calorie count with your patients and help them understand it is not just about the quantity of food they consume, but a healthy quality of foods that they select. You may encounter resistant patients, and it is important to help your patients find pleasure in their foods. Remember, diet is always a choice and not a prescription, and when patients feel they have a choice, they feel empowered and they are better engaged in their treatment plan. This is the visual I promised I would show you, and then some recommendations we talked about in the previous slide. I recommend just taking some time and going to choosemyplate.gov. It has tremendous information about healthy eating and resources that you can share with your patients. The third factor to consider is physical activity. The key takeaway from this section is that your patients should aim for 150 minutes of physical activity per week. Staying active matters because many cellular mechanisms happen when you exercise that will help reduce your likelihood of getting diabetes and improving your blood sugars in a three-step process. First, your body's insulin sensitivity increases when you exercise. This kickstarts a natural process in the body to lower blood sugars as the insulin signal is amplified. Secondly, as your muscles use up stored energy, it will require more energy from sugars. Your muscles become hungrier for blood sugars and consequently absorb the extra blood sugars in your bloodstream like a sponge. And lastly, as blood sugar is absorbed by the muscles, energy is mobilized from fat storage and converted into sugar to be used by the muscles. So think of this process as a natural spring cleaning for your body to use up stored energy in fat cells. Now, beyond the blood sugar benefits, exercise will also give you more energy, lift your mood, improve your memory, and lower your blood pressure and cholesterol. Now, it's not uncommon for patients to ask what is an appropriate physical activity. The first rule is do not get injured. If you have knee pain, any activities with impact on your knees, like running, may not be appropriate. If you have a history of angina or asthma, aerobic exercises that push the limits of your lung capacity may not be appropriate for you. Understand your limits and do not push beyond them. Now, once you understand your limits, the CDC recommends the talk test for a reasonably challenging yet safe activity. The talk test implies that when you're exercising, it should be relaxed enough where you can talk, but strenuous enough where you cannot sing through your activity. Examples of these exercises are like bicep curls with food cans, pushing a shopping cart, wall push-ups, arm raises, and resistance bands. The recommended 150 minutes per week may sound like a formidable goal. Try to help your patients by setting small goals to begin and slowly increase the amount every week. The CDC recommends when setting a goal with your patient, incorporate a plan that is realistic, doable, specific, and flexible. The last but certainly not the least component of lifestyle interventions and counseling is your patient's mental well-being. While your patient strives to keep the body healthy to prevent or manage diabetes using lifestyle interventions, do not forget diabetes is not just a number game with the blood sugars, but also how your patients feel overall. There may be times where your patients may feel stressed, anxious, agitated, or frustrated. The following are some simple strategies to help your patients maintain a healthy mindset. Encourage them to learn to say no to situations where they feel overwhelmed. And they should not try to please everybody while neglecting their own feelings. Encourage them to get enough sleep so that they feel rested and restored. Counsel them to ask for help and realize that they're not going to be able to do it all on their own. Counsel them also to set small and doable goals rather than audacious and unrealistic goals. Somewhere in this journey, your patients will get frustrated and their negativity will consume their mindset. Patients may start to filter and only see their fails, self-label their flaws, or start making excuses. As a lifestyle coach and a healthcare provider, these are times where you need to be honest with your patients and help them see a better version of themselves. There is no room for sugarcoating when it comes to preventing or managing diabetes. We are almost at the end of our presentation today, but before we close, let's put it all together. Lifestyle interventions are a triad composed of weight management, physical exercise, and mental well-being. These three domains are intricately connected. When you exercise, you will subsequently lose weight, which will also make you feel more accomplished. As a lifestyle coach, you will inevitably hit roadblocks with your patients. It is important to realize you cannot try harder than your patients. But before you throw in the white flag and surrender, understand that this is not an easy journey. And like all journeys, there will be setbacks. Rather than coming from a prescriptive approach, try to leverage an attitudinal approach and help your patients build healthy habits. Normalize the failures because failure is a part of the journey and makes your patients more determined. Learn to roll with the resistance rather than fighting it head on. Diabetes can be a very scary and debilitating disease. Helping your patients plan ahead and shed light on the unknown is very empowering. As we've all heard, failing to plan ahead is planning to fail. Lifestyle intervention is a pillar to planning ahead and preventing diabetes. This concludes our last lesson for the presentation. And in this lesson, we talked about guides to lifestyle intervention. We talked about creating an activated patient, which is really the first step to jumpstarting lifestyle intervention for anyone. We talked about the key to weight management, which is losing about 5 to 7% of an individual's weight. We also talked about the essentials of physical activity, which is really getting 150 minutes of activity every week. And then finally, we talked about the importance of mental well-being. And so with this, it ends our presentation on updates in diabetes prevention. We covered quite a bit in our presentation today. We learned that Medicare will be reimbursing for the diabetes prevention program starting April of 2018. Hopefully, this will set the stage for other insurance companies. Organizations interested in offering the DPP to Medicare beneficiaries are encouraged to register to become suppliers of the program. For more information, I encourage you to visit Medicare's Diabetes Prevention Program website. They have updates and webinars throughout the year for people who are hoping to add that reimbursement piece to the existing diabetes prevention program. But today we just provided an overview of what's involved. We talked about how the innovation program led to Medicare developing this program where it is offered to Medicare beneficiaries. We talked about community clinical linkages and the roles and opportunities for health educators. And then we concluded by providing a guide on lifestyle interventions. So hopefully we provided you with useful tools and resources for your practice and education. And even better, hopefully we encourage one of you to take the next step and become a lifestyle coach for diabetes prevention. This slide just shows some of the references and resources that we used for the presentation today. I encourage you to visit these sites as they have tons of information that will help you along. Whether you are interested in becoming a lifestyle coach, you currently work with a company that offers the prevention program, or just whatever sector that you find yourself in, these are useful resources and references to visit. Before we conclude, I want to emphasize that listening to this presentation is just one step in the list of things to be done in order to get credits for this course. You need to complete a quiz that's attached to the course and achieve at least a 70% or better on the post-test. And finally, you also have to complete the course evaluation in order to receive credits. Thank you again for listening. If you have any questions or comments, please feel free to give us your feedback.